Today we will tell you about respiratory system diseases in pregnancy. Let's start respiratory system diseases in pregnancy. During pregnancy, women may face many discomforts. These disorders greatly affect the development of the baby. Generally, not eating regularly, sudden movements, and careless behavior cause these diseases. Respiratory system diseases during pregnancy are the most common of these diseases. These diseases can be caused by the mother's genetics or the mother's careless behavior, smoking, being in the area used, etc. Situations are at the beginning of the causes. Respiratory system diseases. In pregnancy, physiological pregnancy changes. In pregnant women, the diaphragm is elevated up to 4 centimeters. The base of the thorax is widened up to 10 centimeters, and the angle under the costa is enlarged. In respiration, 1. The residual volume decreases, air remaining after maximal expiration 200 milliliters. 2. The expiratory reserve air is reduced, air that can be removed by forced expiration after exhaling normal air, 100 milliliters. 3. The inspiratory reserve volume increases, air that can be taken in by forced inspiration after normal inspiration, 100 milliliters. 4. Vital capacity remains normal, air that can be expelled with maximal expiration after maximal inspiration. Respiratory system diseases in pregnancy. If a decrease in vital capacity is detected in pregnant women, another pathological cause must be sought. 5. The air in each normal inhalation or exhalation, 500 to 700 milliliters, increases tidal volume. 6. Minute respiratory volume increases. 7. Minute ventilation is 50% higher than before pregnancy. This means that ventilation in the alveoli is increased due to more frequent and deeper breathing during pregnancy. As a result of this increase, more CO2 is expelled from the blood, hypercapnia. The partial pressure of CO2 in the blood decreases, and a respiratory alkalosis sets in. However, the blood pH value does not change due to the increase in plasma bicarbonates. In pregnancy, there is hyperemia and edema of the upper respiratory tract, nasopharynx, sinuses, and larynx, changes in the quality of the voice in the chants. Respiratory system during pregnancy. 1. Bronchitis, emphysema. It has been suggested that severe bouts of coughing may lead to abortion. In patients with emphysema, dyspnea may increase in the last months. If these patients with respiratory failure are able to walk and talk easily, a normal pregnancy and labor can be expected. Very rarely, the failure worsens. In pregnant women with chronic bronchitis and emphysema, smoking should be strictly prohibited in order not to aggravate respiratory failure. Expectoration is difficult. Right heart failure is present. They should be advised to stay away from crowded places in order not to get an infection in the upper airways. At the slightest suspicion, protective measures with antibiotics should be taken immediately. If analgesics are to be given against pain in the second stage of labor, pethidine should be preferred. Shortness of breath may increase in the second stage. It is helped by sniffing. Delivery with forceps at the exit as soon as possible. If sectio is to be performed, spinal anesthesia should be preferred. 2. Asthma bronchial. Although asthma bronchial is expected to improve due to the increase in corticosteroid secretion in pregnant women, it has been understood that cortisol in plasma binds to a globulin called transcortin and is rendered biologically inactive. Respiratory system in pregnancy. In the majority of cases, the condition of the asthmatic does not change. In a few cases, it is alleviated, and in a few cases, it is aggravated. The rate of abortion and premature birth in severe asthma cases is not different from normal pregnant women. If seizures worsen during labor, forceps are used. There is no change in the treatment of asthma in pregnancy. Oral antiallergics, tranquilizers, and aerosol inhalations to relieve bronchospasm. In very severe cases, aminophylline 250 to 300 milligrams intravenously plus 40 milliliters, ACTH 2 times a day from the muscle. 10 milligrams every 8 hours. Prednisone every 8 hours. Corticosteroids should not be stopped suddenly, especially against the stresses of labor, bleeding, anesthesia, and surgical intervention. Resistance in the pituitary-adrenal axis is low. Additional prophylaxis with steroids should be given before labor and surgery. If treatment has been discontinued for more than 1 year, additional precautions can be taken only during surgical intervention. In the case of an infection in the upper airways, an energetic antibiotic treatment is necessary, as a preventive measure in the hope that it may resolve bronchospasm. 3. Pneumonia. Pneumonia can lead to high fever, anoxia, and toxins, which can cause intrauterine infant mortality, miscarriage, and premature births. The rate of intrauterine infant mortality and premature birth is very high in the last trimester of pregnancy. If trauma is started at the peak of the disease, the mother's life may also be at risk. However, complications can be prevented with timely and energetic chemotherapy and antibiotics. High-dose penicillin is sufficient in pneumococcal pneumonia. In non-responders, other antibiotics are switched to other antibiotics. In the high fever period, the requirement of 0.2 increases greatly, 10% increase for each degree increase. The hematosis area is narrowed due to the difficulty of blood circulation in the lungs. The heart is under load. Right heart failure and pulmonary edema can be expected. Hypoxia of the fetus is also prevented by O2 inhalation. Pain can be helped with codeine, pethidine. Maternal mortality is high in the last months, at birth and in labor. Meningitis complication is common. Respiratory system in pregnancy. 4. Pneumomediastinum. During dilatation and induration, the alveoli may rupture with strong pushing and result in pneumomediastinum. Air may rise in the mediastinum and diffuse under the neck and axillary skin and into the lung interstitium tissue. Respiratory system in pregnancy treatment. Immediately start 0.2 and antibiotics. Both 0.2 deficit is closed and time is given for resorption of air in the tissue. Secondary infection is prevented. Surgical intervention may also be required in many cases. 5. Pregnancy and tuberculosis. Tuberculosis is a treatable disease. Under appropriate care and treatment, it does not adversely affect the course of pregnancy and birth. Respiratory system treatment does not change during pregnancy. However, if severe intervention is required, it should be left until after the puerperium. The important thing is early diagnosis. Radiological controls without waiting for clinical symptoms are the cornerstone of early diagnosis. Care should be taken to protect the pregnant uterus during radiography. It has been found that the body is exposed to more X-rays in the microfilm method applied in the screening of the disease. X-ray controls should be performed mostly after the 4th month due to leukemia, CO, congenital malformations, and genetic anomalies in children of mothers exposed to X-rays. The effect of pregnancy and labor on the course of pulmonary TB. Under control and treatment, pregnancy and labor have no adverse effect on the course of the disease. However, an exacerbation of the disease can be expected in the puerperium. Lack of sleep, fatigue, and the difficulties of childcare play a role in reactivation. In the past, pneumoperitoneum was performed after delivery. To prevent lesions, and pregnancy was allowed at least 2 years after the inactive period. With today's chemotherapy, the above-mentioned drawbacks have been eliminated. Medical abortion, which used to be a common indication in the past, is only considered in very exceptional cases of poor patients living in very poor conditions. Medical evacuation in patients with severe respiratory failure, shortness of breath at the slightest movement of the body, may be required. Effect of tuberculosis on pregnancy. Spontaneous abortion rate does not change. In severe cases, premature birth may start. Coexisting severe anemia may cause problems. Diagnosis of respiratory system diseases in pregnancy. Bacilli should be searched for in suspected cases, sputum, frottis from the larynx in the morning, even in gastric juice. Culture should not be neglected, and if growth occurs, antibiotic sensitivity tests should be performed. The tuberculin test has no diagnostic value in pregnant women. In some cases of active tuberculosis, the tuberculin test becomes negative during pregnancy. X-ray examination should be continued at intervals of a few weeks in suspected cases with negative bacilli. The possibility of exacerbation after delivery should also be closely monitored by laboratory and X-ray. Cases with active tuberculosis should be controlled and treated in the chest diseases clinic. Care of the pregnant woman with tuberculosis and labor assistance. The mother should be informed about all aspects and cooperate wholeheartedly with the physician. Chemotherapy. Chemotherapy is started without waiting for culture and test response, and chemotherapy is continued throughout pregnancy and for 6 months postpartum. Streptomycin, P-aminosalicylate acid, PAS, and isoniazid, INH, are mainly used. The most important treatment principles: 1. In active tuberculosis, a combination of at least two drugs is necessary. This prevents the growth of drug-resistant bacilli. 2. Treatment should be continued without interruption. Again, the emergence of resistant strains is not allowed. 3. The duration of treatment should not be less than 18 months. 4. Regardless of the drug combination started, the more effective combination should be switched to according to the results of the sensitization test. 5. In pregnant and postpartum women with inactive tuberculosis, prophylactic chemotherapy, NH, should not be neglected to prevent reactivation. In active tuberculosis, only combinations of PS plus INH or streptomycin plus INH have been used so far. All of them cross the placenta. In rare cases, streptomycin may have an adverse effect on the fetus. Recently, ethambutol, ETH, and finally rifampicin, RM, have been used instead of PS. Respiratory system in pregnancy, both have been found to be more effective and have very mild toxic effects. Since their teratogenic effects are not known, there are those who prefer the classical combinations and those who recommend the new drugs for resistant or severely intolerant cases. In practice, isoniazid, INH, 300 mg orally 1 or 2 times. Parasalicylic acid, PAS, 12G orally 1 to 2 times. Streptomycin, 1G parenterally daily. Initially 6 days a week, then reduced to 2 times a week. INH is the most effective. Side effects are also the least. It should be included in every combination. Pyridoxine should be added if the daily dose is above 300 milligrams. PS has been relegated to the second plan in treatments other than pregnancy due to the difficulty of administration and side effects such as nausea, vomiting, diarrhea, flushing, and allergic skin reactions. In severe toxic cases, the disease can be controlled in a shorter time if corticosteroids, prednisolone, are added to chemotherapy at the beginning of treatment. Pregnancy does not preclude the use of corticosteroids. Severe allergic reactions are also prevented. Febrile toxic patients with bacilli in sputum should be hospitalized. Chemotherapy has eliminated therapeutic abortions. Medical abortion may be considered in very rare cases of drug intolerance. Thoracoplasty should be postponed until after delivery. If absolutely necessary, 32 weeks should be waited. The labor policy is the same as normal delivery. Only forceps are used to assist in labor. If the child is large, sectio is performed without straining. Local anesthesia and pudendus block are used instead of inhalation anesthesia. A mother with inactive tuberculosis can breastfeed her child if she wishes. She should observe more rest. If the inactive state is less than 2 years, breastfeeding may be dangerous. Children of mothers with active open tuberculosis should be separated from the mother immediately after birth. The child is given BCG. If the child's weight is low, the vaccination is delayed. A Mantoux tuberculin test is performed 6 weeks after vaccination. If it is negative, the test is repeated after 4 weeks. In the meantime, INH prophylaxis is given to protect the child. The vaccine to be administered must be prepared with bacilli from an INH-resistant strain. If the disease is diagnosed during pregnancy, breastfeeding is not permitted, whether the lesion is inactive or active. If more than 2 years have elapsed since recovery, breastfeeding with a face mask may be permitted until the child has had a positive Mantoux tuberculin test following BCG vaccination. Before returning to the postpartum home, the family environment should be screened, and necessary precautions should be taken if there are active cases of tuberculosis. To summarize, chemotherapy in pregnant and postpartum women, whether the disease is active or inactive, heavy bacillary cases are hospitalized. After birth, if the mother is under adequate and continuous treatment, and the child is protected with BCG and INH, mother and child can be sent home. In new cases, in those who have not been adequately treated, the child should be separated from the mother, and the puerperium should continue to be treated in hospital. Congenital TBC. It is extremely rare for the child to become ill before birth, placental barrage. However, in rare cases, it can be infected through a lesion in the placenta or membranes, through cord veins. The primary complex is in the liver and lungs. A rarer route of infection is gastrointestinal infection by ingestion of amniotic fluid. The primary complex is in the intestines. It can be confirmed by autopsy findings. At birth, the child with congenital tuberculosis looks healthy. It loses weight rapidly. Exitus occurs in 10 days with hepatosplenomegaly and icterus. Thank you for watching.